Dr. Nick Wallace is an orthopedic spine surgeon who practices at our Ortho Spine Center at Southlake, at our Southlake campus in Maryville. And he's going to speak about spine pain and back pain and treatments that can help your quality of life. And without further ado, Dr. Wallace, the floor is yours.
Excellent. Thank everybody for coming tonight. I'm going to share my screen so we can all see the presentation together. Okay. Are you able to see the PowerPoint presentation?
Yep.
Yes, sir. I think everyone, I think we're good. Thank you.
Excellent. So we'll just get started right away here. Let me see if I can advance these slides. One sec. Okay, so I'll have to use the mouse. I have no conflicts of interest regarding the content of the PowerPoint, so no concerns there. A little bit about myself. I grew up in Grand Rapids, Michigan. It's about 2 hours drive north of here, small town in Michigan there. After finishing high school, I ended up going to Utah for undergraduate, my undergraduate degree, where I got a bachelor's in science. After completing my undergrad, I traveled down to Texas at the University of Texas and obtained my medical degree there at Houston, and then subsequently matched into orthopedic residency at the University of Michigan. And again, I moved back to Michigan for 5 years, where I trained on performing surgeries on the hands, shoulders, legs, and the spine. After completing the 5 years of residency, I then dedicated an additional fellowship year to learning surgeries of the spine, and specifically only the spine. The fellowship was a year long at Madison, Wisconsin, at the University of Wisconsin, where I tutored under the surgeon Thomas Zadevlik, who is a well-renowned, world-renowned spine surgeon up there. And then after completing my fellowship, I came down to Maryville to start practicing spine surgery here at Methodist. So to begin our discussion, I wanted to kind of get everyone on the same page and do a little anatomy lesson on the spine. So as you can see on the slide, there are 33 separate bones that comprise the total spine, going from the cervical spine near the base of the neck, into the thoracic spine, where all of the ribs are connected. And what we'll be talking about is at the bottom of the spine, the lumbar vertebrae. There are 5 free vertebrae that attribute a lot to the bending of the lower spine, and can account for a lot of the back pain that people experience throughout their life. So overall, the function of the spine is really to keep our body supported. So it supports the arms, the head, the entire thorax, all of the ribs and the contents within the chest, as well as the abdomen, and keeps us in this upright standing position. As we're bipedal creatures, we walk around on 2 feet, unlike many of the other animals. And so the distinct curvature of the spine is unlike any other spine in any other animal, in that we have these curves that allow us to stand upright in an economic way. The secondary function is also to house all of the nerves that enter into our arms and legs. And they run from the base of the skull through the canal in the middle of the spine. And at each level, there's an individual nerve that exits the spine. And it'll give a sensation to our arms. It'll give signals to our muscles to contract. And it can give us additionally some sensation of hot, cold, pressure, temperature, that kind of thing. Like I said, we're going to focus mostly on the bottom 5 vertebrae. These are called the lumbar vertebrae. It's right when the spine transitions out of rib-bearing vertebrae into the more mobile segment called these lumbar vertebrae. Now, these are the biggest vertebrae in the spine. They carry most of the weight of the upper body through them. So as such, the body has adapted to growing much bigger and broader vertebral bodies, which is kind of the column that supports all of the different vertebral segments. At each level, as I described before, if you can see this picture on the right, there's a nerve root that exits out of this special hole called the neural foramen. And each of these nerves send signals down to our legs. At each level, we are at 5 levels. Each nerve has a specific number ranging from 1 to 5. And then we have one nerve that exits through the sacrum below the lumbar nerves, which also innervates a lot of the muscles and the sensation nerves in our legs and our feet. So when we talk about low back pain, it's a very common malady that affects the vast majority of the population. In fact, they did epidemiology studies looking at back pain in all populations of the US, and they found that throughout any lifetime, there's about a 50 to 80% chance that someone is experiencing some type of low back pain that would require them to visit a doctor. It's about $100 billion every year that costs our health systems. And it's the second most common reason that we have a doctor visit. Many of the risk factors that are associated with back pain tend to be somewhat modifiable, including obesity. So people with a BMI greater than 35 tend to be a higher risk of having low back pain at some point in their life. Smoking is surprisingly a very big risk factor. What happens is as you smoke, it actually inhibits a lot of the blood growth that is required to heal small injuries of the spine. And as you have many years of smoking, it accelerates the natural degradation that occurs, or the deterioration of the spine that naturally occurs with age. Those people with smoking habits tend to have a much more advanced arthritic back than those that don't smoke. Females tend to have a little bit more lower back pain, likely as a result of the differences in hormones that are present in females. Estrogen tends to cause ligaments to be a little bit more lax than they otherwise would be. So those hormone cycles tend to allow a little bit more motion throughout the spinal segments, and that can lead to faster degradation of the spine. And then lastly, people that have occupations primarily focused around heavy lifting or frequent vibrations or sitting for prolonged periods of time, they tend to be at a heightened risk for back pain as well. This is a list of the 6 most common reasons why someone would present to my clinic. Now, the first 3 items tend to be more common, but less severe in nature. So these are what you commonly think of when you think of back pain: muscle strains or tendinous strains, pains that stem from disc injuries that we talked about before, those soft cushions between the bones, and then facet degeneration. And these are these specialized joints of the spine. Let me go back a couple levels so I can show you. On the back here of the spine, you have these articulations or joints, much like the joints of your knee or your hip, where you have cartilage. And these joints allow the spine to bend forward and extend back. And they quite literally glide against each other, much like the knee bones glide against each other when you're walking. They also glide as you're bending forward or twisting your spine. So the forces that you see in your knees that kind of cause it to deteriorate, also those same forces are present in the spine, and those joints can deteriorate much like the hip or the knee does. So to look a little bit more at muscle strain, by far this is the most common cause of back pain. And as you can see from the diagrams on the right, there are hundreds of muscle attachments at the many different levels of the spine. And whenever you're standing upright, these muscles are engaged in keeping your upright posture. So any kind of traumatic fall or potentially direct trauma to the back, or even overuse can cause a tear in the muscle belly, which is on the picture, that this red, can you see my mouse? Maybe not. Let me see if I can show you. Can you see here? This muscle belly that is indicated by the red fibers of the back. This muscle belly can tear and cause significant amount of pain that is aggravated by activity. Because it's so painful, your body kind of responds to that by stiffening up the back, and it's almost protective to prevent any further injury to the muscle from occurring. So when you have a muscle tear or tendinous injury, your body signals you that you shouldn't try to use that muscle as much as you normally do, and you interpret that as stiffness or pain with some bending. The typical treatment for a muscle strain tends to be conservative, as long as it's not a complete tear. You can use cryotherapy, which is heat pads, cold pads, to help calm the muscle down from spasming. Non-steroidal anti-inflammatory drugs such as Aleve, ibuprofen, meloxicam, those help to prevent any of inflammation from really getting out of control. And those inflammatory markers tend to sensitize the nerves and make it more painful. You can also use special medications such as muscle relaxants to help prevent those spasms from occurring too much. And then mostly it comes down to activity modification for most of these tears. As long as you give it some time and you don't re-aggravate that muscle tear by overusing it, the muscle will heal itself and that pain goes away, usually within a 6-week period. Now, disc and facet pain is a little different. Disc and facet pain refers to the degeneration of these intervertebral discs between the bones, and then those special joints on the back called facets that articulate between each level. Now, this kind of pain is more so consistent with a pain like arthritis of the knees, if you're familiar with that. It's a deep bony pain. It's usually aggravated by overuse or a lot of activity. Bending or sitting for prolonged periods of time tends to stress the discs, or overextending can really aggravate the facets on the back of the spine. Lifting heavy items can also stress those joints and cause the pain to get worse. It usually is only back pain. You don't have much pain that radiates outside of the back. And this tends to get worse with age. So as you use the joints, as you can probably think that, well, just like using the knees or the hips, the more you use the joints of your back, they tend to wear out a little bit faster. The treatment for this is also pretty conservative. So just like the muscle tears, NSAIDs are a great form of controlling the pain. It takes the inflammation away from the joint as well as the disc, so they're less sensitive. Weight loss can help decrease some of the load that you're experiencing across the joints. And if you can decrease the force across the joints, that tends to help quite a bit with the pain that is generated at those joint sites. Like we talked about before, smoking is a big risk factor for degeneration of the spine. And stopping smoking can be almost protective of those joints going forward. In some instances, if the pain does not improve with just activity modification, then you can start physical therapy and stretching exercises. These tend, as you see on the far right, to focus on the muscles that support the spine, the perispinal muscles, as well as the core muscles, so your abdomen, your rectus, all the oblique muscles of your side. If you can strengthen those muscles, that they tend to help quite a bit with keeping the overall spine stable and decreasing the amount of stress and pain that you experience at the joints. There's also options for cognitive therapy, lifestyle modifications, and in some instances, you can get steroid injections around the joints to help calm down those inflammatory molecules. So now that we've covered the first 3 most common causes of back pain, the second 3 are types of pain that most likely will have you visiting someone like myself, a spine surgeon. These types of back pain tend to either require surgery or need some sort of advanced care in order to make sure that they are treated properly. These tend to not get better by themselves, but with some guided and appropriate medical care, they can have significant improvement and allow you to have a significant improvement in your quality of life. So the first one I want to talk about is a disc herniation. Now, these discs tend to tear mostly just from millions of cycles of daily activity. So at each disc, and I'll kind of talk about it in a later slide, there's a tougher, leathery outer covering, and then a softer, more cushiony portion. And as that outer covering starts to cycle over millions of times. There's these micro strains that occur. And as those build up, there's a risk for an overt tear straight through the cover, allowing that cushion to get pushed out. And if it pushes out and pinches a nerve, that's when you start having radiculopathy. Usually this occurs in the 3rd to 5th decade. So 20-year-olds, 30-year-olds, 40-year-olds, they tend to be the most common age population that tend to have these. As you get into your 6th, 7th, 8th decades of life, most of the soft cushion of your spine tends to be worn away, and it's much less common to have a herniation beyond your 5th decade. Usually about 10% of people will experience this at some point, and about 5% of those become symptomatic, or they have the pain that shoots down the leg, numbness and tingling, maybe some weakness associated. And there's a pretty heavy skew toward the male gender with these injuries. So like I talked about before, here's the diagram. This is the side view on the left of a healthy disc. If you take a cross section right through the disc, it looks kind of like the diagram above it. So on the outside here is that tough, leathery covering called the annulus fibrosus. This keeps all of this soft, almost crab meat-like material called the nucleus pulposus in the center. This is where you want it to be. This is where it serves the best function. It's a good cushion in between each of the bones. But over, like we talked about, millions of cycles of bending, twisting, lifting, you can get these micro injuries around the annulus that cause it to get weakened, and at one point it can tear. If it tears, then this soft pulposus, or this crab meat-like material, can get pushed out, and it can pinch the nerve as it exits the spine. Now, this is the less common area that it herniates. Typically, there's an area right in the middle of the spine where it's a little bit weaker, and it tends to come out and pinch the nerve right here, and in the paracental region is where it's called. Now, what happens when this occurs? Usually, the most common story that I hear when someone comes in with a herniated disc is they'll have a moment, either some sort of fall, or if they're picking something up where they can feel a pop, or they'll feel like a sharp tinge in their back, but nothing that goes down the leg. And then over the next coming days, they start to have these new pains that go down the leg, numbness or weakness in the leg that slowly gets worse over the next week or two. Now, the pain can be very excruciating. It's unlike any other pain that you've really felt when you have a pinched nerve. Nothing really makes it better. You can usually try some NSAIDs, some resting, doing some cryotherapy. But really, the only thing that is going to make that pain go away is a little bit of time. Often people, when they're sitting or bending forward, that tends to make that pain worse, or coughing and sneezing can actually cause more of that cushion to get pushed out and make that pain shoot down the leg. Now, the treatment options for this, as I said before, most commonly, about 90% of the time, it'll get better with non-operative care. So just resting, activity modifications, avoiding any positions that cause that pain to get worse. NSAIDs can help for the first 3 to 4 weeks, muscle relaxants if you're having spasms of the muscles. And occasionally you can do an oral steroid course and physical therapy. Now, 9 out of 10 times, this pain will get better by itself. And the body will naturally send some enzymatic proteins and some white blood cells to eat away at that herniation to create room for the nerve. And that usually occurs within the first 4 weeks. If it doesn't get better, or if it gets better a little bit, but still is causing a lot of pain, that's when you see a spine surgeon to discuss potentially needing a microdiscectomy, where you have to go in and physically take the pressure off the nerve. We reserve these kind of procedures for patients that have greater than 6 weeks of symptoms, or if the pain is progressively getting worse day after day, week after week, or if you have significant weakness. The risk of having significant weakness in the leg with a pinched nerve is that it could be permanent if it's left alone for too long. So the microdiscectomy is a minimally invasive surgery. It's about an inch-long incision right in the middle of the back. We use a special microscope or an endoscope, which are these special cameras that are placed at the ends of these tubes to visualize the spine and get down to that herniated disc. And it takes about 30 minutes to do. It's an outpatient procedure, so you're going home the same day. And then you follow up a couple weeks later just to make sure that the wound is healing and you're getting improvement. Here's some representative images. This is that special microscope that we use in the operating room. It has a magnification up to 40x or 40 times normal size, so we can work through a very small incision, get down to the nerve safely, move the nerve to the side, and get that disc fragment out. These are special retractors that we use in order to keep the skin and the muscles separated so that we can see down where the nerves are. And this diagram here, the image here, kind of represents the general approach to get down. So the nerves, as they leave the spine, cover up where that disc herniation is at. So we use these special metal retractors, or kind of, I guess retractors is the best way to call them. These kind of metal probes to move the nerve out of the way, and so we can get these surgical graspers to get down to the level of the herniation and pull that fragment out. The post-op course is relatively straightforward. The first 2 weeks, you want to avoid any aggressive activities just while the skin is healing. For the first 4 weeks, there's the highest risk of having a second herniation. As your body is healing, there's a slightly about 5% chance that you have more of that soft disc material get pushed out. So I try to have all my patients for the first month try to keep to light activities. I encourage walking, I encourage light stretching, but heavy lifting or aggressive running should be avoided for those first month. After that first month, you're able to go back to full activity, no restrictions, and in only rare instances where you've had significant amount of weakness before the surgery, you'll have a physical therapist help get that leg strong again. The second item I want to talk about is spinal stenosis. Now, this is a disease of the spine where you have a generalized tightness that occurs circumferentially around the nerve sac. It's a combination of different mechanical pressures that occur at the nerve. The first thing that typically happens is you have the degeneration of the disc that lead to a bulging effect, and that crowds the canal where the nerves live. Once the disc starts to degenerate, you have this abnormal motion that occurs at those facets of the joints of the spine. And your body's response to that abnormal motion is to grow those facets out or add more bone to those joints in order to limit that pathologic motion or that bad motion. In addition, there's a special ligament called the ligamentum flavum that gets a lot thicker, or hypertrophies is the medical term for it. All of these combine to cause the canal where all the nerves are living to get much tighter, and that starts causing a lot of pain in your back and then your legs. Usually all of these effects tend to take time to develop, and the peak incidence of having this type of problem is those individuals older than 65 years old. There's about 1 in 4 people that actually experience this kind of pain in their back at some point in their life, and there's, again, a slight skew toward the male gender. Here's a graphical representation of what's going on. So on the left, you have this diagram of a healthy spine. This is a cross-sectional area. So the front of the spine is in the top, the back of the spine is on the bottom of the image. And in the middle here, this is where all the nerves live. These green dots represent all the nerve roots of the spine. So in a healthy disc, the disc covering is nice and taut, and it doesn't encroach at all into the center of the canal. These facets on either side of the spine are nice and clean, and the ligamentum flavum that I talked about before, that special ligament, is nice and narrow and taut. Now, if you get degeneration and you lose some of the cushioning of the disc, all of a sudden this disc starts bulging into the canal and makes these nerves crowded, and they start to pinch them. Secondarily, these facets start to grow bigger in order to try to limit that pathologic motion. And these ligaments here on either side also thicken. All of these combine to cause these nerves to get pinched right in the middle of the spine, right here. This is the MRI that shows that exact same condition. Very hypertrophied facet or overgrowth of the bone on each facet, bulging of this disc here. And on certain instances, you can get these cysts, these fluid-filled sacs that pouch out from the joints that can also add some tightness around the nerves. Usually patients come into clinic mostly with back pain, but the pain is very classically described as pain that gets worse with standing and pain that gets worse with walking. Usually it's when they're upright that the spine actually slips a little bit and causes the pain or the tightness around the nerves to get worse. And as the longer you stand, the longer those nerves are getting pinched and the more pain you experience. Again, usually it builds up in your lower back and your buttocks, and it can start spreading down to your thighs and into your legs. This is a special term for this is called neurogenic claudication. And that's just the medical term for that pain building up over time as the nerves continually to get pinched. The best thing to help alleviate that pain is sitting down. So if you flex the spine and you sit, that stretches out those ligaments and stretches out that disc so it doesn't buckle into the nerves, and it causes the nerves to have more room so they get less painful. Often people, when they go to the store to shop, they'll get a shopping cart and lean over it. That similarly causes the canal to get opened up, and you're able to walk for a lot longer distances. The treatment for this is kind of similar to a disc herniation, but you want to continue the conservative management for longer. Early on in the disease, you tend to get these flares that last for a week, maybe a month, maybe a couple months. And if you can get through those acute flares, it'll go back to where it was before, and you're at a more functional level. So during those acute flares, you want to use NSAIDs, maybe a little bit of physical therapy, some weight loss to decrease the stress across the joints, and then occasionally an epidural injection where they put some steroid right on top of the nerve to calm it down. So all of these treatment options are indicated for patients that have had symptoms less than 6 months. In more advanced cases, when the tightness is so intense that it doesn't get better after the conservative measures, and you've really tried earnestly to treat it for 6 months, that's when you start talking about surgery to more permanently take the pressure off the nerves. So these epidural steroid injections we'll kind of just touch on briefly. You want to target the nerves as they are in the middle of the spine, in that canal, or as they exit the spine. There's a couple different levels that targets you can aim for. The doctors will use these special X-ray machines that are portable that they can bring into the OR called fluoroscopy, and that shows exactly where the needle is at, and they can confirm that the medication is going right over the nerve. It's an outpatient procedure. Usually it's less than 30 minutes. You can go in and get the injection and go home the same day. And what's really beneficial is that it can serve both diagnostic information for the surgeon, letting the surgeon know that the pain is stemming from the nerve. So if you have a muscle strain, or if you have some degeneration at other levels, if you get better from the injection, specifically targeting one nerve, then you know that is the specific nerve that's causing the problem. And so you can address all of your treatments for that nerve, or potentially surgery if needs be. The secondary benefit, and probably more important to the patient, is this therapeutic benefit of pain relief. So when they inject the steroid over the nerve, it causes the nerve to be less sensitive. So even though the pressure doesn't go away, the nerve gets a little bit more robust, and it's not quite as sensitive to that pressure, so the pain can significantly improve. Usually you can get about 3 or 4 injections every year. So if the injections are lasting 3 or 4 months, it's probably a better option just to continue getting injections rather than considering surgery, which has a lot more recovery and a lot more risk involved with that. Here's an example of an epidural injection occurring. This is that special X-ray machine called a fluoroscopy machine. It's a mobile X-ray, and as you can see on this TV in the background, it shows exactly where that needle is going into the spine. Now, the surgery option for stenosis is called a laminectomy. This also is a minimally invasive procedure. It's a little bit larger of an incision than the microdiscectomy, maybe about half an inch more. But you're still using the same instruments. You're using a microscope to really look at the nerves and make sure that you're not damaging them, or an endoscope, which is that camera attached to the tube. The surgery is a little bit longer than the microdiscectomy because it involves taking a little bit of bone away that's causing pressure on the nerve. So it's about an hour-long surgery, but you're still able to go home the same day, or if not, the next day. This is what the surgery looks like. From the back of the spine, you have these bony bridges that form the neural arch. And this is the location where a lot of the pressure is occurring between the ligaments of the bone and then the bone itself. So in order to take the pressure off, what you do is you remove the lamina. Lamin refers to the lamina of the spine. Ectomy is a medical term for removal. So you do a laminectomy, you remove the lamina from the spine to allow these nerves that are residing in the canal to have more room to breathe. Here's a little video that we can show that kind of explains it. So here's a patient laying on the operative table, face down. The dotted line is the incision through the skin. You take that incision down to the level of the bone, peel away the muscle, and you use these special burrs to take down the lamina in the spinous process. So here it's showing the burr taking down that bone. Sometimes you have a herniated disc that needs to be removed, but as you take the pressure off of those nerves, they tend to straighten out, and all of that pain that's going down the legs tends to improve significantly. Again, this is about a 60-minute procedure, and you're going home the same day or maybe the day after. The post-op course is a little bit longer than a discectomy. So again, the first 2 weeks, you really want that skin to heal. So you're doing minimal activity for those first 2 weeks. And then the ensuing 4 weeks, you can get back to light activity. Again, stretching, lots of walking. You just want to avoid any heavy lifting or twisting. Then you come back to clinic at 6 weeks. And at that point, as long as the muscle is healed, the skin is healed, and you're feeling good, then you can return to full activity. Again, physical therapy is reserved mostly for those patients that have either a slow recovery or if they've had significant weakness before surgery. Now, the last thing I want to talk about is spine instability. And the special term, medical term for spine instability is spondylolisthesis. Now, this refers to when a bone in the spine or one of the vertebrae starts to slip in front of the one below it. This is typically caused by the normal degeneration of the spine, but certain criteria tends to be present for most patients that have a slip. They have a lot of degeneration of the discs that leads to some instability at the disc level. And as that disc level tends to slip more and more, it can actually affect the orientation of those facets. And if the facet gets injured enough, or if they're oriented such that they don't really block that slide from occurring, that micro instability, that those little micro motions can turn into macro instability or very visible slips that you can see on the X-ray or the MRI. Usually this happens in patients older than 40 years old. It's about 10% of patients actually have these slips in their spine. And it's a very heavily skewed female pathology. And it's theorized that it's because of the estrogen that's present in females throughout their life that it causes this ligamentous laxity in the ligamentum flavum and all of the ligaments that attach to the spine. As they become more lax, they tend to have that instability pronounced throughout their life. Now, you can get pinched nerves several different ways when you have a slipped vertebrae. Most commonly, as depicted in the picture, this L4 vertebrae slips forward, the corner of the bottom vertebrae starts to encroach on the bony arch of the level above. So this posterior corner of L5 starts to pinch the nerves across the arch of L4. Now, here's an MRI picture on the right of what's going on. This is your L4 vertebrae slipping forward in front of the L5 vertebrae. And right in the middle here is the spinal canal. This is where all of the nerves live. All of this bright white color is a fluid or a water that surrounds the nerves. And you can see that it disappears right at this corner as this back portion of 5 starts pinching across this bony arch of L4. And it causes all of these nerves to get squished, and it causes it to be very painful. Pain that shoots down the legs, pain that causes a lot of back pain. The second way that you can get some pinched nerves from a slip disc is through these narrow foramen, or these windows that the nerves pop out of the spine at. So if you see that, look at the X-ray to the right. Here's the L3 and L4 vertebrae. Nice tall opening where that nerve can come out. And that's because you have this very tall disc in between those 2 bones. When you lose that disc with the spondylolisthesis, then you lose the height that is present between the 2 bones of L3 the vertebrae. And this is where you get significant tightness and pain from a pinched nerve. This is the MRI kind of showing that same picture. Nice and tall space for the nerve to come out. And right below that, this is where that slip is. All of that space is gone. And the nerve that leaves this foramen is going to be very painful. And that's how you feel the pain that shoots down the leg. So spine instability or spondylolisthesis tends to come to clinic or my clinics with a lot of back pain. And occasionally you can have that shooting pain down the leg as well if the nerve is getting pinched as it travels down that slip level. It's usually a lot worse when you're standing and walking, but it improves when you're sitting or laying down as you take the load off of the spine. Much like spinal stenosis, the first option always is non-operative care. So as far as the back is concerned, surgery should always be your last option. You can always continue conservative management without any irreversible effects on your spine. The one way that you cannot go back from is to get a spine surgery, particularly if it's not indicated. There's no way to undo that spine surgery. So you really need to be conservative with choosing to do surgery only when it's indicated. The mainstay for this is physical therapy and getting those muscles strong. So as you can imagine, as that bone slips forward, the only way to really have to counteract that slip is to get those muscles strong and keep it pulled back. So exercise programs to strengthen and physical therapy regimens to strengthen your paraspinal muscles are typically what helps the most. Weight loss also is a great way to diminish some of that pain. As you're taking the load off of the spine, it won't slip as much. Sometimes you can trial these epidural injections like we talked about before, but these tend to be less effective with instability because the nerves are getting pinched in a very mechanical way. So as the spine slips, it's pinching those nerves. And the injections won't necessarily stop that pinch from occurring. Usually you want to try these for 6 months of conservative measures. But like I said before, if it progresses to the point where it's still painful despite these measures, these treatments after 6 months, that's when you start talking about surgery. And the surgery is a decompression with a fusion procedure. Many people are kind of hear about spinal fusions, but they're not really sure what they are or when they're indicated. This is one of the times where it is very much indicated to do. When you're having these symptoms for greater than 6 months, you have instability of the spine, or you have a slipped segment of the spine, or if you have dramatic weakening with that instability. The surgery is a decompression with fusion. There's many different flavors of what this really entails. You can do an open or minimally invasive surgery. Open is a single midline incision right in the middle of the back. Minimally invasive surgery tends to be a little bit more muscle sparing, so less pain postoperatively, less of a hospital stay. But you're kind of limited at how many levels you can do at one time. Fusion with or without screws is another thing that surgeons may talk about. There's fairly good evidence that using pedicle screws, or these special screws that insert into the bone with rods, increases the success of a fusion by about 10 to 15%. So it's enough of an improvement that it's generally recommended to have these screws placed if you're getting a fusion. Rare instances, if the bone quality isn't great, or if a patient is very sick, wouldn't tolerate a long surgery, then you kind of consider not doing a surgery with screws. Secondly, you can talk about inner body cages. This is kind of getting into the weeds a little bit, but like I said, if those windows that the nerves come out shrinks too much, the best way to restore that height or the window for the nerve to come out is to put a spacer in between the bone where the disc used to be. That allows the disc to get, or the space for the bone to be restored where it naturally was with the disc, and it can take the pressure off the nerve. The surgery for this is about 2 or 3 hours, and it's an inpatient procedure, so you're typically staying 1 to 3 days, depending on how fast you can progress with physical therapy after surgery, how well the pain is controlled, and what kind of support system you have at home. Now, the number one goal of these surgeries is to get the painful motion of the spine to stop. So you really want to stop that motion, and to do so, you get the bones to fuse together. These are different options that the surgeon may talk about going from the front. That's called an anterior lumbar interbody fusion. If you go directly from the front, you can go obliquely from the side. You can go directly lateral through the side of your waist. A TLIF is probably the most common surgery that's performed, and that's kind of using an oblique from the backside approach to this inner body space. And less commonly, historically, one of the more common used, but now less common, is a directly posterior inner body approach. Now, all of these approaches have their pros and cons. And if it gets to the point where you do need a fusion procedure, you can go into the details, the risk profile, the benefit profile of all these different approaches to do that surgery. Here's a representation of kind of what needs to get done with this surgery. Preoperatively, you have a spine with this slip disc, pressure or narrowing of the canal coming out where the nerves are, narrowing of the inside canal where the nerves are traveling down the spine. And so the first thing you do is take the pressure off the nerve. You do a laminectomy like we talked about before, where you take the bone away, allow those nerves to kind of float back and have less pressure on them. Then you take these screws and insert them into the bone. You pull the bone that had slipped back in place. And in this instance, they placed a metal spacer in between the bone to kind of restore that natural curve that the discs usually have, but the patient has lost over time due to degeneration. Here's another video kind of depicting how those screws are placed right into the bone at each level, between the 4 and 5 level. You distract across those screws to cause or create space. Take out these 2 segments of bones of the facet to access that disc space. You cut a hole into the annulus, and you take out all of that soft crab-like disc material. In its place, you put new bone to allow it to fuse. And often you'll put these metal or plastic spacers to keep that bone from collapsing back down. And then ultimately you backfill it with some additional bone, and it allows to fuse in between those bony levels. Finally, you put these rods in between the screws to hold everything in place to allow your body to fill in all of this space with new, strong bone. And that'll essentially be good for the rest of your life. The postoperative course is a little bit longer with these fusion procedures because you need the bone to heal. The first 2 weeks, again, you want that skin to heal. That's the first box to check, minimal activity. Then the first 3 months is you can start doing some light activity, but you really want to refrain from going back to full activity until that bone fully heals. Most people will heal that bone within 3 months. And you get a series of x-rays over time to monitor to make sure that bone is filling in, healing properly. At that 3-month mark, as long as the bone looks nice and solid and healed, then you can get back to full activity gradually. So little increases in your activity every day. Physical therapy, again, is only reserved for patients with slow recovery, or if they have a lot of weakness that they need to recover. after surgery. That can be a little bit helpful to have a therapist on board guiding the recovery time. So in summary, back pain is a very common problem. About 80% of the population at some point of their life will experience back pain. Most of the time, back pain is treated conservatively. So you do not need surgery for the vast majority of instances where you have back pain. But if that pain is persistent, more than 6 months, or if you have significant weakness and numbness present in your legs, that's when you want to consider talking to a spine specialist. For those special circumstances such as disc herniation, spinal stenosis, and instability of the spine, those may require surgical intervention. So I want to thank you all for spending some of your time this evening, learning more about the spine and hopefully getting a little bit educated and enlightened about low back pain. I'm going to